Morning. Welcome to our session, Changes Ahead, No Return to the Old Normal. I'm Cynthia Baur. I'm the director of the Horowitz Center for Health Literacy at the University of Maryland College Park, and I'm happy to be here today at the opening plenary to be your moderator for two very interesting presentations, and I hope a lively discussion. So before we turn to our speakers, I have some housekeeping work that I need to do. The first thing pertains to questions. If you have any tech questions or questions about the conference, please see the virtual help desk located on the conference homepage for contact information. This session has continuing education credit. So to get that credit, you must fill out the session evaluations and the overall evaluation. Please visit the evaluations found on the homepage to fill these out and get your CE certificate. To let you know, today's session and all other sessions today are being recorded, and you will be able to access them within 24 hours. For today's session, for the questions and the discussion, please use the questions tab to send your questions in for the speakers. Each person is allotted 100 points to vote with, and that automatically populates through the live stream. The more points that a question gets, the higher it will show up on our question list. Please use the discussion tab to send your thoughts and comments to all attendees. If you are having trouble with the live feed, please try refreshing your screen and pressing the play button. Okay, with that, I think I've covered everything in terms of the housekeeping, and we're ready to get started with our session. So to kick us off today is Dr. Neal Sikka, who is a professor and a practicing emergency physician at George Washington University. He has over a dozen years of experience providing and developing telehealth services. He's the fellowship director for the GW Telehealth and Digital Health Fellowship Program and has led a number of projects, one of which he's going to talk to us about today, called Health Desk, an academic community partnership on digital health literacy. So welcome, Dr. Sikka.
Thank you. So thanks for the opportunity to share a little bit about our program called Health Desk. So we built this program following on a previous grant that the DC Healthcare Finance, DC Medicaid essentially had provided us to expand capacity for telehealth in underserved parts of Washington, DC. That was back in 2018. And we did that in partnership with the Pennsylvania Avenue Baptist Church. And that was a really exciting project. We were able to build a telehealth clinic within the church, but it was we learned a lot about the challenges in engaging community members to utilize telehealth. And I think this has been one of the challenges with using technology in healthcare, or specifically with offering telehealth services. And that is often, if you build it, no one comes. And that's for a variety of different reasons that we'll explore during this talk. Health Desk was a follow-up grant funded through DC Healthcare Finance and was actually awarded to the church, and we partnered with them. Developed closely with the church leadership, with our community volunteers, and with my digital health fellow, Dr. Alam. And so in essence, Health Desk is a digital health literacy pop-up, and we'll go into some more details about that. Next slide, please. So here's the list of objectives for this session, and we'll really focus on digital health literacy and how the digital divide has become so much more apparent during the pandemic, and how Health Desk has tried to tackle some of these challenges. Next slide, please. So what is Health Desk? I want to go into further detail. What it is a pop-up. It was a community and academic partnership where we bring together volunteer digital health coaches who are both community members and members of the academic medical center to work as a team. And we really focus on meeting our DC residents where they are with technology and helping them understand and become more comfortable with improving self-care, leveraging their mobile devices. And so, I think we're all becoming more attuned to the fact that there are multiple aspects to the digital divide, And it goes way beyond just access to technology and connectivity, but really the knowledge and comfort and the possibility of utilizing the technology to improve your health. So we spent a lot of time talking to community members, trying to understand what those barriers might be. And we continue to do that work actually in grants even today. But trying to design and provide content and coaching that could be meaningful, useful, and actionable to a resident, whether they're having an acute medical problem that they're dealing with today, or if they're managing the health of a family caregiver, or if they're just trying to manage their own health, like a chronic condition that's been ongoing for a long period of time. Next slide, please. So who are health desk volunteers? I mentioned the previous grant where we set up the telemedicine clinic. We had at that point recruited about 15 community volunteers who came from really all walks of life within the community. Many of them were very active in the church, but others were both in and outside of the healthcare system. So some people were nurses, some were technicians who worked at different hospitals within the city. Others had nothing to do with the healthcare system. But I would say the theme that was most common within our community volunteers was that they had either suffered through some type of a complicated health condition where they felt like they had to fend for themselves to navigate the healthcare system, or they had a family member that they cared for and that they had to support through that same type of challenge. And so health desk volunteers were recruited through the church leadership, through a variety of different like newsletters and church marketing, social media, apps like Nextdoor and Instagram, all of these types of mechanisms were used to try to identify volunteers. And then the volunteers would go through a training program. And the training program was focused on two aspects. One was kind of content, and the other was operations. So if you start with operations, there's various roles to make a health desk pop-up work. You need to have someone who helps kind of engage community members. So if the pop-up shows up at a community health event or even a non-health but community event, we really wanted people who are comfortable to go and talk to folks and kind of draw them in. The second was a technician. So someone, we called a technician. So someone who could really hands-on support a resident through, working on their own device to make it work for them. And then finally, you have to measure the impact of your program. And so we had folks who were kind of focused on exit. And those were, doing satisfaction surveys, providing giveaways and freebies at the end. And then there actually were leadership roles. So folks who would help to schedule and organize and make sure people showed up and set up. And so everyone had their own comfort zone. And that was part of the design of the help desk, that it had all these different layers. So if you were a volunteer, you could slide yourself into where you felt most comfortable. The training content was about 4 hours. It was built into a Google Classroom. It was delivered multiple times, both in person and then online as the project went on. Next slide, please. So as I mentioned, those different roles, there is a process for the help desk, and it's really modeled after the Apple Genius Bar experience. Very seamless, very digital, very efficient. Usually. So we would show up, we would set up our tents, and we developed a digital registration system. So we had iPads all mounted into kiosks, and our registration staff would be wandering around an event and draw someone in. And then, as you can see in this photo, bring them to the kiosk. And at the kiosk, we would register the person. And so that would be actually staying away from a lot of personal information, but focusing on why are they there? What are they struggling with? And would they want to be connected to credible and reliable resources? And at the end of the registration process, what we would learn about is, okay, if we're offering content in 5 or 6 different areas, please select the one that you're most interested in. And then they would get handed off to the technician to do that one-on-one coaching. but it was really designed to eliminate paper, make it a digital experience, develop a positive atmosphere, and kind of set the stage for this kind of one-on-one coaching relationship. Next slide, please. So the coaching, as you can see in these images, was very personal, and it was often one-on-one or one-on-two, where we could pair a community member with a volunteer from the academic medical center. And in certain scenarios, we actually brought in, I would say, expert coaches. So in this one of the images here, you'll see someone with the laptop, and he is a IT staff from our practice who was able to help patients register for their patient portal. That took a lot more time and expertise, and so having someone with a lot of experience there was very helpful. What we found during these coaching sessions was that community members tended to shy away a little bit from the technical coaching and really focus on engagement. And our students and our academic medical center volunteers tended to do the opposite. They tended to shy away from community engagement and want to stay at the technician desk. So I thought this was kind of an interesting paradigm that we learned. And really, as the help desk hopefully returns into its in-person format after the pandemic, we will work on reversing that, because we really want to build more comfort level with our coaches from the community to be able to provide this type of technical assistance. And we want to make sure our students, our residents, our faculty become more comfortable interacting with the public and in the community and engaging community members. Next slide, please. And then, of course, step 3, that's where kind of the fun is. This is where the hugs happen, because I have to say the number of times, a community member kind of had a eureka moment with their device was quite frequent, and it was really, incredibly impactful to them. May have been something they'd been struggling with for a long time. Often we would find that, a patient's device, maybe they couldn't download an app because when they bought their phone, it had a lot of advertisements and other kind of garbage stuff built into their phone. And we just were able to show them how to delete those things and remove it. And now they were able to download their photos or, download their patient portal or do something else. So that was one, takeaway from almost every encounter was just the incredible kind of gratitude that there were people here to help them do this in person and not just kind of on the phone as a, kind of an anonymous technical support, but really this kind of in-person coaching. Also, everyone was asked to fill out a survey on whether this was a useful engagement, and of course, take something home to remember us by. We had a lot of stress balls. We were surprised at how much stress and how much interest there was in stress management and meditation and mindfulness that we found among those who attended the help desk. Next slide, please. So these are some of the types of coaching that we provided, both on digital health applications and around phone optimization. And actually, we really focused on phone optimization first, even though I apologize, it's listed second on this slide, because we really felt like we needed to build the basic knowledge and comfort with utilizing their device. And also, a lot of our pre-work and interviews had illuminated that there's a lot of barriers to adopting or downloading an app. People are somewhat hesitant due to privacy and security concerns, or even just logistical concerns. For example, a lot of us may not recognize this, but even if you ask a patient to download a free app, depending on the last time they may have updated their credit card information with Apple, for example, in the iOS store, in the App Store, the App Store may ask you to confirm your credit card information. And even though the app is free, it suddenly changes the perception of that app being free because it's being associated with a credit card confirmation. And so those are just some of the barriers that we've learned, and we've sometimes call these kind of adoption mechanics, trying to understand what are those things that might drive adoption and what are those barriers that might limit adoption. So things as simple as helping someone who may be having difficulty with their vision, increase the font size on their phone. That was incredibly helpful to a lot of people. Some people didn't know that there were colorblind settings and that they could enable voice commands. One other very popular feature that we were able to help people with was using the phone alarms to set medication reminders. You know, for a long time, kind of the mobile health and digital health push has been to find an app that helps you with a chronic disease. And like I mentioned, there are a lot of barriers to downloading an app, but if you can use innate phone functions like a medication alarm, I think people have a lot less privacy and security concerns around that. And so we had a lot of fun trying to help people set those up, because you can customize the text associated with your alarm, the times, and how often it reminds you and things like that. So definitely an activity we did a lot of. And then on the application side, we really focused on patient portals. You know, I think historically healthcare systems have been incentivized, but struggled with the adoption of a patient portal. And being able to share with community members the importance and the value of being able to own your own data, to be able to take it with you if you're receiving care. For example, in DC, there's 8 different hospitals. You could end up, you know, getting your care at Georgetown, but ending up in the ED at GW. And sharing of that data, of course, is often challenging. So the value of being able to port your own data with you is incredibly important to relay. And then as an ER doctor, probably one of the most important takeaways from my perspective was having patients fill out the "in case of emergency" feature on their phone. I find, you know, I could tell that story over and over and over again. You know, if by chance something happened to you, you had a stroke or a heart attack or a traumatic injury where you could not communicate with us, the "in case of emergency" will help us identify if you have allergies to any medications, if you're on blood thinners, or if we can identify a family caregiver who we may be able to communicate with. So I think people really kind of heard the importance of that, and we had a lot of people adopt the "in case of emergency" feature. Next slide, please. So here are just some of the outputs we measured from our community members. We trained 8 kind of trained the trainers, and then they trained about 22 more. So we had about 30 volunteers who became trained during the time period of the health desk prior to the pandemic. And about 300 residents visited health desk activities, at least those that we were able to count. And you can see here what people were most interested in. Hypertension and healthy lifestyle was definitely at the top. And the activities that people were most excited to learn about are listed here as well. But in case of emergency and alarms, font size, and the patient portal, and as I mentioned before, meditation and stress management were big ones. We had a partnership with Headspace, the meditation app, and so we were able to provide 6 months of free access to that application. And actually, Headspace came back and has now started to work with Medicaid providers to provide Headspace as a benefit to those patients. Next slide, please. If you look onto the community, the impact on volunteers, both in the community and at the medical center, I think it's just been really outstanding. It's opened the eyes of our faculty to opportunities and challenges with using digital health. I think the students who were able to spend time with us out in the community, just their comfort level in communicating with residents, especially shifting outside of the clinical setting, where a lot of medical students and PA students and often other students from a variety of different domains. We had nursing students, we had PT and OT students who would show up and volunteer. All of them this is a change of setting, because often you're only communicating with your patients, when you're in a hospital setting or in a clinic setting, and now you're able to communicate with them in a community-based setting and have these kind of one-on-one relationships that you may not have when you're outside that clinical setting. So I think, all of us really benefited from it. And the community volunteers, were engaging with a lot of their community members they knew or didn't know, but they also found this comfort level with the volunteers from the medical center. They got to see how dedicated our volunteers were, how committed they were, and how hard they worked to make this happen. And so I think it really did build relationships on both sides. Next slide, please. So as we get close to here, wrapping up, a few more slides here. The help desk really was a one-on-one, in-person kind of activity. And when COVID hit, we were no longer able to do these in-person activities. And so we've struggled now with how do we transition all of these learnings and these methodologies into some type of a new format. So we took our first step, next slide, please, which was creating help desk shorts, where we did interviews and short videos around COVID content. And they were, I think, moderately effective. We were able to have some reach through the church and through their Facebook Live activities and partnering with other community groups, but really didn't have kind of the energy to scale this kind of content. So we've kind of gone back to the drawing board. Next slide, please. And now we're really going to focus on developing more digital health coaching curriculum that can be distributed. We think that that's probably our next step, because as people recognize the challenges with poor digital health literacy and digital literacy, they need a roadmap. They need information, as we all do. How do I teach my colleague to be able to, on the fly, when they're with a patient, give them basic phone optimization and promotion types of information. And I think a lot of us just don't know where to start. So we are starting a new study where we're going to recruit patients who've never had a smartphone and go through the process with them. We're going to provide them a smartphone and we're going to coach them through onboarding on that device. And we're going to try to kind of document where the challenges are, what are the simple things that we can do in short periods of time. And then the end product of that will be content that we can share with lots of people to be able to then pass that on to their patient population. Next slide, please. So we really need to make patients more aware of the patient portal. I think that's one thing that we've learned. We need to make them aware of online scheduling resources, telling them about resources to be able to find devices. And then you have to keep promoting this at every visit, every time you interact with the patient. So once you've gone through that content, you know how to educate your end user. You need to keep promoting it, because over time, I think people will change and they will start to realize some of the value. And where the return is on the healthcare side is that if your patients are more comfortable utilizing this technology at home, it actually will make your practice more efficient and their engagement with your practice more efficient. So if patients can become comfortable with online scheduling, well, that may take the load off of your phone scheduling. Or if patients have access to their health data now, they don't have to call and request lab results or other explanations. So I think there's a real benefit for engaging patients in digital health. Next slide, please. And so here's a proposed tiered approach to improving digital health literacy. This is what we'll be testing out in our next study. But looking at how do you help people with innate features? So setting up their phone, making calls, emails, and using text. Sometimes it's as basic as that. A number of our patients didn't have email addresses, and we were able to help them set up a free email address. Using the camera, because it's such a social kind of activity. Connecting to Wi-Fi, turning on their phone as a hotspot. And then security and privacy are big ones. And sometimes patients don't understand how to use their lock screen. And so that's another set. So that's where we think is like the very, very bottom, where can we help patients? And then we move into kind of more advanced features. So adding contacts, setting alarms and reminders, changing the font size, in case of emergency I mentioned. So these are things that still don't require an app download. They are still advanced features of your phone, but don't require you to go and put something on your device. And then in the last stage, the more mature stage is, well, how do you download or utilize a video chat app? How do you install anything that you might want to install, and how do you assess whether it's something credible and useful? Using the patient portal, of course, one of those I said is of critical importance. Self-tracking is becoming, I think, more and more popular, and it provides insights into how to manage your health. And then remote patient monitoring is a emerging area. And so as there are more and more Bluetooth and Internet of Medical Thing devices, how do people connect to those? I mean, if you purchase them, you got to connect to them. And you don't know how many times in the ED I see a patient with a smartwatch, and I say, oh, did you record your heart rate on that smartwatch when you had palpitations, or did you look at this, this or that? And often people don't even realize the power of the data that's being collected and how they might be able to utilize that. Next slide, please. So how can this be implemented? I think hopefully there's some takeaways here about how you can educate your teams and yourself, and become more and more comfortable with the common challenges that patients face with technology. You can prioritize making your patient base more digitally literate, because we know there's benefits to the patient and to the practice. And you can become more comfortable with applying these skills. And I like this, at the bedside and the community. And I put this image here because things are completely changing. We will be emerging into kind of this new normal. And maybe we're afraid of that. Actually, one of my colleagues has been terming this kind of fear of the new normal, or FONO. But you can see here, like my ED looks like it vomited out all of its equipment into the rooms, because when we were dealing with the height of COVID, we wanted to keep our rooms as clean as possible. So it'd be simpler to turn those rooms. And so everything is vomited out. Now things are moving back in, but they're different. Not everything moved back in. They moved back in maybe new locations and in new ways. And so hopefully we'll be able to adapt these strategies to help our patients adopt digital technologies in a new normal. Next slide, please. That's all I have. Thank you.
Great. Thank you so much for that very interesting presentation and look at the work that you've been doing in the community. Before I go to our next speaker, I want to encourage you to post your questions to the speakers. We should have plenty of time for discussion and Q&A. So on to our second speaker for this session, Dr. April Joy Damian. She is an epidemiologist and health services researcher with expertise in health equity, social determinants of health, psychiatric epidemiology, and mixed methods. She currently serves as the Associate Director of the Weitzman Institute, which is a research, education, and policy center devoted to primary care transformation. I think we could also use transportation, right? With a particular focus on vulnerable populations. So welcome, Dr. Damian.
Great. Thank you so much, Dr. Baur, and thank you to the IHA staff and to all of you for the opportunity to join you this morning. So Dr. Sikka and I were charged with this plenary session, and I believe the topic was changes ahead, no return to the old normal. So you just heard about the role of digital literacy and technology, which is clearly played a major role, and telehealth is definitely here to stay, as is digital health literacy. The focus of my talk is more on the behavioral health changes and recognizing that, in addition to COVID, we've experienced and observed or witnessed converging pandemics, including a mental health crisis. So my focus for this morning is understanding and addressing adverse childhood experiences, which I'll refer to as ACEs, and adverse communal environments, which are the social root causes I would describe of ACEs in the context of COVID. Next slide, please. So for those of you who are less familiar with ACEs, and maybe this is a refresher for those of you who are already familiar with this topic, the original study conducted by Filetti and Anda back in the 90s out of Kaiser was looking at 3 subdomains of ACEs. So there's abuse, neglect, and household dysfunction, and you see the different subtypes within of those domains. Their study predominantly looked at this in the context of upper middle class white female population who are insured. So just giving you context. But since then, so close to over 25 years, we've learned a lot about ACEs and looking at ACEs in the context of health disparities. So next slide, please. So the CDC collects data on ACEs through its surveillance systems, behavioral risk systems across the country. And we see that their Giano study published last year looked at the frequencies and disparities of ACEs in the US. And we see that females, persons of color, those in the 25 to 34-year-old age group, LGBT populations, low income populations, those with limited education and who are in what we call blue collar positions, had a higher frequency of ACEs compared to their respective counterparts. So recognizing that there are these disparities based on different demographics that exist. So that's what we've learned in the last 25 or so years. Next slide, please. And I want to note, and I'll go into detail about ACEs in the context of COVID in a little bit, but just wanted to note that, stress in childhood, often ACEs is interchange and there is overlap with childhood trauma, but to note that there are different types of stress. And I'm sure all of us have been exposed to some degree of this stress, right? There's the positive stress, which, for a child might be, taking an exam. I know there are some exceptions with the examples I'm giving. The having exams, starting in school helps prepare one to be able to handle stress and know that, you can commit to a goal and excel in it and work really hard for something that really matters to you or helps with your own professional or personal development. There's the tolerable stress. So think of, what happens with stress and challenges, but in the context of having a mentor or a supportive adult or all these buffers. Then there's the toxic stress, right, on the far right. And this is what we're really interested in terms of, COVID, for example, as a stressor. You think of the impact it's had on a child's development, even on adults, in terms of school disruptions, not being able, for those who might be the first in their family to go to college, the difference in not being able to connect with, loved ones or teachers or even their friends after school, and that socializing component that's so key to their development. So what happens when there's this toxic stress, so we'll call the stressor COVID, and there's no adult or buffer to be able to offset the stressor that they're being exposed to, right? So this is what we're most concerned in, these lifelong consequences, everything from chronic medical conditions to substance use, challenges with learning, mental health challenges, cancer, and even early death. Next slide, please. So I just want to show that, although ACEs happens earlier on in the life course, there are long-standing challenges on one's health and health behavior, physical and mental health over the life course, right? This goes on into our geriatric patient populations, and knowing that there's a dose response, meaning that the higher the ACE score, the higher risk for these unhealthy or risky behaviors, as well as adverse physical and mental health challenges. Next slide, please. But I'm mindful, given that I'm in public health and an epidemiologist, we don't solely look at ACEs in terms of the individual, but also looking at social root causes. So I just love this image because it really shows that, and so will the next slide, that, in addition to these ACEs that we might see as, say, the fruits of public health challenges, there are social root causes that are contributing why certain populations are experiencing ACEs at a higher rate than others or higher prevalence than others, right? We know that there's historical or intergenerational trauma, greater exposure to communal violence, lack of employment, poor housing, and lack of affordable housing. Here Washington, D.C., we have a huge homeless population and issues with housing instability, poor access to social capital and social mobility, right? So understanding that, yes, ACEs, we can look at the individual level or even within a sub-patient population, but really understanding that are these communal factors that have historical and structural root causes that can explain why we see these disparities in ACEs, right? And I will go into the environmental piece as well later on in this presentation. So next slide. So this is to zoom in to what I was talking about, right? So the ACEs in terms of the fruits or the leaves of the tree, but really looking at the roots of why, one, are we seeing ACEs, and two, why are we seeing ACEs disproportionately affect certain populations more than others? Next slide, please. So now that we've all level set it in terms of what ACEs are and then the social root causes of adverse communal environments. Thought that was important background so that we're all on the same page. Now I want to talk about ACEs and the direct and indirect pathways linking pandemics to ACEs. So I'll just go over 6, but there are several more of linking pandemics to ACEs. So next slide, please. So there's the economic insecurity and poverty related stress. So you remember these are the social root causes, so to speak, of the ACEs that we see in terms of the fruits of the tree, right? So we know that a lot of businesses have closed, including small businesses. There's a spike in unemployment applications and unemployment rates, right? Huge growing homeless population, which is complicating the already existing challenges with housing insecurity. And we know that there's food insecurity, right? We think of how our youth who depend on free or reduced lunch in public schools, and what happens when schools are, have to pivot to remote, and those lunches or meals that they count on might be their only meal that they have in a day are no longer available, right? So what happens, and knowing that, not everyone, I was very fortunate, and I'm sure Dr. Sikka, Dr. Baur, several of us are very fortunate in that we might be in positions where our work allows us to be at least partly remote, right? But knowing that those who are responsible for ensuring, sanitation of our streets, of buildings, who run our grocery stores might not have the same privileges, right, of being able to conduct their work either fully remote or partly remotely. Next slide, please. So there's also quarantines and social isolation, right? We're hopefully coming out of the pandemic and beginning to see the light, but recognizing that, social isolation in terms of children who might, usually go to school and being able to engage with, mandated reporters, those who are experiencing abuse. I know in the initial weeks back in March 2020, they saw a dramatic drop in child abuse reports and in intimate partner violence reports, right? Examples of ACEs. But it's not so much that abuse suddenly stopped, right? It's that those who are mandated reporters, such as teachers, counselors, healthcare providers, might not have the same degree of interaction with parents, with families, with children as they would schooling be in person, or would more of our activities that are usually done in person. This sense of isolation and having to quarantine has put those populations who are at risk of ACEs at greater risk, right? Because they're not able to engage with those who would be able to grant them or connect them with the professional support that is needed. Next slide, please. There's also greater exposure to exploitative relationships due to changing demographics, right? And we know that African American and Latinx populations, so this is from the LA Times, who are disproportionately affected in terms of deaths related to COVID, right? And so understanding what happens to those persons who are left behind when loved ones who they relied on, either from a financial standpoint or a social standpoint, are no longer available, right? So what happens when children now have to live with, maybe an abusive family member, or there's disruptions in the household, right? Or those that were the head of household and were financially supporting other family members are no longer available now that we know that there are increases in child labor challenges, not just in the US, but also globally. So recognizing that there's this greater exposure to exploitative relationships as a result of disruptions in household composition. Next slide, please. So we also note that there's reduced health service availability and access to first responders, right? So as healthcare responders, like Dr. Sikka, are responding to COVID, we know that there's already this is something that I study and continue to address here at Weitzman. We already know that there's a shortage in terms of our primary care workforce, right? And so what happens when your healthcare workforce now has to pivot and focus on COVID related challenges, right? It's not that these other health challenges, including my focus in terms of mental health, all of a sudden are no longer important or have gone away, right? But knowing that when you already have this surge in demand and your first responders now have to focus more on COVID, the first responders who may usually be available, and this is not solely limited to healthcare staff, but also, law enforcement, those, who work in fire departments, now have to pivot and focus more on COVID, but usually would have been available in terms of responding to cases of abuse or violence, are now tapped out, so to speak, and have to focus on the current pandemic. So recognizing that this reduced availability and access to first responders also puts a higher risk in terms of not only exposure to ACEs, but being able to address them in a timely manner. Next slide, please. So there's also virus-specific sources of violence, right? So we talked about in our article in the Harvard Kennedy School misinformation review about health literacy, and the head of WHO talked about the challenge of misinformation, which was a new word that I learned as a result of the pandemic, and how the infodemic, right, of misinformation being used to scare people. We're hearing that in terms of what's contributing to vaccine hesitancy, but perpetrators of violence may use misinformation to control or blame women and children, withholding safety items such as hand sanitizer, masks, disinfectant, withholding health insurance or economic support. And then we know that there are also social and economic repercussions of the infection, such as stigmatization, violence, and destruction of property from family community members. And there are emerging studies that have shown that all of these have increased since the start of the pandemic. Next slide, please. And last but not least, I want to highlight, inability of women to temporarily escape violent partners, right? So what happens? So I pointed out earlier in terms of social isolation and quarantine because of the pandemic and because of policies that were, stay-at-home policies that were put in place. But oftentimes the case of having to stay with violent partners is from a financial reason, right? Not only for the women, and in case I'm giving an example of women, although I know that intimate partner violence also happens with men, but in this case, I'm talking more about women. Might stay with an abusive partner, not only for themselves from a financial standpoint, but also for their children, right? So understanding how IPV, or intimate partner violence, which is a type of ACE, has also heightened because of limited resources that might be available to be able to escape violent partners. We know that courts also during the pandemic closed. So, when there are usually these procedures that were happening in person in the courts were delayed because of the pandemic and different government institutions closing during the pandemic. Next slide, please. So I just wanted to highlight a few statistics for all of you to consider. This is from the National Institute for Healthcare Management or NIHCM Foundation. So we know that, before the pandemic, 14% of households with children were experiencing food insecurity. That doubled during the pandemic. Families with children accounted for a third of the homeless population before COVID, but we know that because of mass unemployment, that there is increasing homelessness, and this is nationwide. I talked about IPV in great detail in my earlier slides. And then this last box on child abuse and neglect, that, child advocacy centers, so I talked about these mandated reporters, are seeing fewer children during the pandemic. And so, children becoming increasingly vulnerable during the pandemic, increased stress as a predictor of abuse, school closures, so having fewer contacts with adults to identify warning signs. Next slide, please. So before the pandemic, 1 in 6 children faced a mental health condition, right? So it's depression, anxiety, as some more prevalent examples. Though experts suggest that the impact of the pandemic will only worsen mental health for children, right? So we're only about a year and a few months out since the pandemic, but you can imagine not only the more immediate but the long-term consequences that the pandemic will have on pediatric mental health, not only in their current stage of development, but over time, which we will continue to have to study. We know that increasing poverty rates, when I talked about earlier about those root causes, poverty being one of them, of adverse communal environments contributing to ACEs, could increase by 53%. Parents having to quit or reduce work hours because childcare not being available, right? Oftentimes, childcare, I know some of the schools here in DC provide childcare or extended after school programming to assist with working class families, and what happens when that's not available and parents have to reduce hours, which means reduce finances being available. And then this relates to Dr. Sikka's talk about digital health literacy and knowing that there is a digital divide, right? And knowing that there are Black and Brown communities that are disproportionately impacted, including rural communities disproportionately impacted by the digital divide. And so what happens when classes are taught remotely, but not everyone has access to a laptop? I know for some schools in here in DC, they had a several months waiting period because Dell just ran out of computer, like could not keep up with the demand, because it's not just schools that needed laptops, but different businesses were going remote, right? So what happens when they don't have internet access or computing devices, and what does that mean for their educational attainment? And we don't know the outcomes of being left behind, so to speak, in education, what that could mean long term. Next slide, please. So I just want to highlight, our focus so much and which is justified, has been on COVID, and pointed out mental health crisis as a converging pandemic, which has really been the focus of my talk. But I just want to highlight that there were other public health challenges, which I'll say is natural and man-made because it relates to our climate crisis, right? We had hurricanes that resulted in billions of dollars of destructions, California wildfires, and you can imagine the disruptions this had, not only on youth and families, but also on small business owners. Next slide, please. And this week, we recognize it's the 1-year anniversary since the murder of George Floyd. And that during this pandemic, we've also seen, recognizing this is also Asian American Pacific Islander Heritage Month, that we've also come to reckon moral reckoning with our country's 400-year public health crisis of racism, right? So understanding that these natural and man-made disasters, whether it be hurricanes, wildfires, racism, all contribute to a growing mental health crisis, right? It can exacerbate the adverse childhood experiences and youth development. And knowing that those challenges, as I've reiterated throughout my presentation, don't just have ramifications in early childhood, but over one's life course. Next slide, please. So I never want to leave a presentation as if all is doomed, right? There is hope. Dr. Sikka talked about, being able to partner with churches in the communities. And I think, as advanced as we get, and as much as I love technology, I'm not the most technologically savvy person, that there is value in people, right? That the communities have that rapport with each other and can build resiliency and overcome public health challenges. So what does it mean for us as healthcare and public health professionals, as researchers, to be able to not just do our research, our innovations, our initiatives in communities, but with communities, and making sure that they are at the table and making decisions with us and not just at the receiving end. Next slide, please. Understanding that, some of these examples include being able to partner with faith-based organizations. We know that there are medical societies that have a particular focus on African communities and are by African American providers. We know in the African American community that fraternities and sororities play a huge role in the cultures, and what does it mean to also partner with those entities? Next slide, please. So just as I noted in the beginning of intergenerational trauma, I also want to note that there is power in the intergenerational connections, and that, those who might be in the millennials or those who are growing up in an era where it's less of a stigma to talk about mental health can create these opportunities in family settings now that families are gathering not just in person but also remotely and leveraging Zoom to be able to communicate with each other, to understand that yes, it's okay to use Headspace, right? And like, what does it mean to communicate with your grandma or your older uncle, a family member, to say yes, mental health may have been stigmatized and we don't talk about mental health, or that cousin who has issues, but to normalize seeking mental health support, and to make it a part of a normal conversation on our family tables. And next slide, please. So that is it for my end of the presentation. So I'll turn it back over to Dr. Baur. Thank you.
Thank you so much, Dr. Damian, for that sobering look at vulnerability and also giving us some ideas about how we can speak to that. So we have been getting some questions in for our speakers, and I will turn to those now. So Dr. Sikka, we got a question from several people that wanted to know a little bit more about how much time your teams, your coaches spent with each person who was using the help desk services. So both initially and then any follow-up in terms of some of the activities you were talking about, like, for example, helping them get an email address or learn how to use their phone. So if you could just talk about the amount of time that was needed to do all of those things you discussed.
Yeah, that's a great question. What we observed in our community activities, so that mostly when we set the pop-up up at health fairs or community events, the throughput was about 15 to 20 minutes with each person. And we did try to limit, the kind of the technical coaching to one or two activities that were most important to folks at that time. So time, the throughput in a sense in this type of intervention can be a challenge. And so if you're trying to adapt that, into a clinic setting or such, it could be very difficult. But there's lots of, ways you might consider that. It's as if you could leverage, any of your staff. Doesn't have to, if you're in a clinic setting, for example, it doesn't have to be a nurse or a doctor doing this type of coaching. It could be almost anyone who's had a little bit of comfort with their devices. Other ways to leverage student volunteers and other folks who are trying to get exposure into the healthcare system. I think this is another great role for them. I mean, a number of our volunteers were actually pre-medicine students who wanted to get more exposure in the community. From a community volunteer standpoint, I think, like I said, it's kind of this transition as people became more comfortable with teaching. Things go a little bit faster, but we're also good at kind of handing off, oh, there's other people who might be able to help you. You have a grandson, he might be able to, he might be more comfortable with technology. So make sure when you have a question, go back to them. And we are trying to build this dialogue with people who attended at a health desk. That, again, got disrupted by the pandemic. And so we now are trying to figure out how do we go back to build those relationships.
Great. The people were also interested in any follow-up because you did speak to the fact that people completed a questionnaire at the end of their encounter. Was there any other follow-up that came after that?
So the questionnaire was really designed on trying to use kind of marketing tools to understand if this was an engaging type of mechanism to work with the community. And so we used the Net Promoter Score, which some of you, if you're in marketing, you may be familiar with, and folks in healthcare have started using this as a way to see if a service would be recommended. So the Net Promoter Score for the help desk was extremely high. It was, I think, over 80 or something like that, 82, 85. So very, very high. But in follow-up, when people registered through our digital kind of intake, they did check a box as to whether we could email them. And we have tried a variety of campaigns to email back out to folks who attended the help desk. And it's been with, I'd say, moderate success. I think, a lot of emails were incorrect. People either didn't put the complete email address or they put a wrong email address. So that's a limiting factor on how you verify correct communication. 2, we didn't have a text messaging option where we could directly text to a phone. We could only email to a phone. Based on the technology platform we had built. And we built this all basically with very minimal amount of money and very little technical expertise. We built it on a Google platform using all the Google kind of Drive suite applications with some students and faculty who had some experience with this. And we were able to recruit some members into other studies. So for example, when Headspace wanted to further understand how the population was using Headspace, we reached out through that network and were able to acquire some community volunteers to join those studies.
Thank you. So Dr. Damian, you alluded to the fact that the pandemic introduced you to this concept of misinformation, and you talked also about the digital divide and sort of how that coincides with so many other factors for the families that you have been studying. So could you speak a little bit about sort of your thinking now in terms of the role that like health information seeking and some of the sort of technology approaches that Dr. Sikka was talking about? How does that sort of fit in this mental health space? Because, there's a concept that many of our community have, is familiar with, of mental health literacy, but that has been traditionally been thought of as just being able to recognize signs related to mental health challenges. But it's really not gotten into like the health information seeking, the decision making, the sharing of information, a lot of the things that those of us in the health literacy community have been interested in. So could you speak a little bit about sort of how what your thinking is today in terms of sort of how do people who are kind of coming from your perspective and, primarily concerned with mental health issues, and those of us more on the health information side, what is your thinking about where we might come together on some of these issues?
Yeah, no, that's a great question. So we covered in that article that I reference, and I think it's available for free for those of you who want to look at it. Um, that this is really an opportunity for public health, which I would say is where health literacy and health IT has really lived in, so to speak, and primary care to converge, right? So often when we talk about health promotion, health communications, that's really been done in public health, and not so much looking at it within the primary care setting. So this is really an opportunity for the two to uh, join our forces, so to speak, as we have during the pandemic. Um, Part of it, and this is the literature supports, is the need to start internally within health workforce staff, because as much as there's been a lot of emphasis on medical mistrust, which I'm not ignoring, it definitely continues to exist and persists, but there's also a lot of trust in healthcare providers, right? And so what does this mean to make sure that um, healthcare providers and healthcare teams in the largest sense, right, from the medical assistants, the physicians, to registered nurses, even community health workers, that their own questions and concerns about the pandemic, about vaccines, about the use of apps and digital devices. I was just actually answering this question internally earlier this week, that they feel comfortable about all of the different, I guess, the evolution, so to speak, and continued growth of technology as it plays out in healthcare, right? So understanding that, if a healthcare provider or a member of a healthcare team is not comfortable with technology and is kind of downplaying its importance within healthcare, that will have an impact in how their attitudes that they're conveying to patients, right? So what does this mean to do in education internally? I think there's the other piece. So I talked about earlier, community-centered public health practice, right? So what does this mean to lean on the leaders in the community, whether that be leaders of nonprofit organizations, faith-based organizations, which Dr. Sikka has done, to make sure that it's not just us, who is, I would say, helicoptering in as a researcher and saying this is the best stuff in sliced bread, but someone that they already have established rapport with, making sure that they're on board and conveying those public health messages or public service announcements to their congregations or to the populations that they reach. And I think the third piece is also is understanding, and this is why I like the headspace. So this is helpful because we know that Mike Phelps is one of the spokespersons for Headspace, right? And is talking about his own challenges with mental health. And so what does this mean? And I know that they've also leveraged celebrities in the past, Elvis Presley in terms of the polio vaccine. Today, we have NBA players and John Legend saying the importance of getting the vaccine. So the same goes for us, right? What does this mean to go outside of the people we traditionally partner with, but knowing that there are other more influential voices, right? Mayor Bowser had Michelle Obama as part of a public services announcement to stay at home DC, right? So what does that mean to partner outside of the circles that we're used to engaging with in our efforts, so that they're the ones who are the spokespersons for what we're trying to do. And I will add a fourth. I usually say things in three, but I think the fourth is understanding what do the populations and the patients that we serve want, right? Like what's challenging about the technology? Like what, is it, fear of privacy? Is it just not knowing how to use it? Is it not being able to pay for it, right? So, sometimes it's as simple as asking to be able to better address and come up with solutions.
Well, the health literacy community, you're in the right place. The health literacy community is all about seeing things from the perspective of the end user or the person who's getting the information or trying to access the service. So you're in a very friendly environment when you say things like that.
That's great.
Dr. Sikka, I got a question here about digital health literacy, that this person has been seeing that term used more often. And his observation was that you were talking about digital literacy in a health context. So if you could say a little bit about this from your perspective, do you think that people could potentially get confused and maybe some of the health literacy issues could get overshadowed by a focus on the technology?
Yeah, that's a good point. I think you're probably right. Maybe we are focused on digital literacy in a health context, and the term may not be fully accurate. But I think we know the power of technology can impact lots of different aspects of someone's life, and so while we're focused on kind of building that digital literacy and then explaining what we do, right? Our expertise is in health. So how can you access the healthcare information you might need to improve your health? But it definitely bleeds into social, economic, education, a lot of other areas. And so, for example, one of the areas in our new study that we'll be doing where we provide a phone to those folks who've never had a smartphone before is that hotspot component is really critical, because if you're in a multi-generational family and you have kids at home who are trying to log into virtual school, that maybe a hotspot would enable a better connection than a connection you may have. So I definitely think that that it may not matter so much. I mean, we're really, as long as we can improve understanding of how technology can be used, then it can be used for applications that are patient-centered, right, or that are people-centered for what their current need is. We know that healthcare needs are not always front and center, of course, and they're often only front and center at a time of crisis. And so if we have to be the vehicle to improve technology literacy, then that may be the case. But lots of people are working on this, and they'll have their own context for it, and it will bleed over into health as appropriate.
So Dr. Damian, we got a question for you about children specifically who've spent quite a bit of time in the last year online, both for education and other reasons. As they come back and are doing more in person, is there anything that you would advise people to kind of be ready to do to support teachers and other professionals who work with children in terms of helping them make this transition from this intensely online world back to an in-person world?
Yeah, so just to make sure I got the question, it's more of the youth serving workforce and how to
Yeah, it
support
said,
youth
are there
serving workforce?
resources for teachers and other professionals who work with children to help them, like with their emotional learning, their communication, as they're coming back and, kind of coming out of this bubble they've been in this, kind of, as you were describing, this more sort of isolated environment. They haven't had access to their peers, their teachers, social workers, things like that. They're now going to start coming back into contact with this kind of larger world in a more intense way. Are there any resources or advice that you would give to people who are in those kind of, helping roles?
Yeah, I mean, one resource online which I've used for a very long time, probably for the past 10 years, is the National Child Traumatic Stress Network. So that shows, evidence-based practices in dealing with children who've experienced trauma, because, I talked about adverse childhood experiences, or ACEs, and the disparities, but at this point, every child has experienced some form of trauma because of COVID, right? Like a school disruption. I talked about the unemployment rates, right? So understanding that there are evidence-based practices out there, and even if teachers are not clinicians on that site, there's also resources on how teachers can engage with licensed therapists and clinicians who specialize in childhood trauma, right? So the teachers already are overworked, and I can have a whole different, which I have a separate podcast on on just the mental health challenges that teachers have to deal with in the classroom, but understanding that there are licensed professionals, and it's also a great network to be able to engage with, because especially for our educators who might be in rural areas and might not have the same resources within their own city, in the same city or town, then there's that online resource support or portal to be able to engage with other practitioners and from different disciplines from across the country. I think the second, which we wrote about, it's an article in the Journal of School Health, is the need for teachers and, assuming that if there is a school-based health center co-located within the school, that there's greater communication and interaction between those different entities, right? Sometimes school-based health center this has worked independently of educators. And what does this mean for those who are physically co-located but not have necessarily pre-COVID worked together to now collaborate with each other and know that, okay, if a teacher is observing signs of depression or anxiety or challenges with a child being able to transition back into the classroom, can they then refer the student to a licensed professional within the school-based health center? Then I think, there's also a responsibility not solely from teachers, but administrators to ensure that there's mental health support for educators, because there is what's called secondary traumatic stress or vicarious trauma. And in terms of providers, usually I've studied it in healthcare provider setting, but it's also translate to other youth serving settings where those who work with populations, youth, and families who've experienced trauma are experiencing indirect trauma, right? Burnout from it. So we know that teachers are already at risk for burnout, or if not, they're already burned out. So what does this mean for administrators, those who are in leadership positions, to ensure that, teachers have, allocated time and the resources they need to promote their own self-care and mental health?
Great, thank you. So Dr. Sikka, we got a question about the curated content that you talked about. If you could say a little bit more about where that content came from and the curation process.
Sure. So, what we found was that a lot of folks find information in a lot of different areas, and actually I've partnered with some new different companies that are looking at this in different ways. But I think, information gets passed down from a variety of sources of variable credibility. And so we struggled with that, trying to figure out what are credible sources for different communities. And we've decided to settle in, and this requires much more exploration, but we settled in on pre-pandemic, sites that were fairly consistent. So CDC, the American Heart Association, there were a few other curated sites I'm trying to think of, that come from agencies like HRSA, government sites that have content that are actually built for different communities and different cultures. We tried to stick to those and look for content that was at a pretty low education level, that was easy to consume and understand. We really liked content that's video based, so we didn't have to worry about reading literacy. That being said, I think, what we've experienced through COVID is that sometimes government agencies are not going to be considered trusted, and we probably need to take a better look at that as we go forward. I found that there was a better uptake and impact, I think, when you looked at some of this curated content, when I would go through content with a person at the pop-up myself. So if someone had a question about hypertension, we could talk about it, and then we could go to our health desk website and say, oh, here's a video from the CDC that kind of reiterates this, so you can watch it again at home. And I think that definitely helps with the concept of credibility, because it comes from someone that you've seen and trusted, and then it gets repeated. But I can also see now, especially living through COVID, how there can be confusion and maybe distrust of some of those sites.
Great, thank you very much. Well, we're down to our last couple of minutes for this session, and I thought I would just put in a plug for those of you who are in locations that have either a school or program of public health. So in both of the talks, it came up sort of how do you do that community engagement in a more sort of direct way. I would encourage you as someone in a school of public health to really think about the public health programs in the areas that you are in, because there's lots of students who are looking for that hands-on community experience, and they're trained in public health, and they could be great partners for you as well. So I want to thank both of our speakers here today for bringing us two very interesting perspectives on how the world has changed and continues to change around us, with a focus on how the pandemic is specifically bringing us a new set of circumstances. We heard about how technology can play a role and some of the mental health and other challenges that many families are facing. And I think we can all agree there's plenty of work still for us to do in a post-pandemic world. So thank you very much again for joining us here today. And I'm supposed to remind you to complete the individual session evaluations and the overall conference evaluation by visiting the conference homepage. So thank you again, and I hope you enjoy the rest of the conference.